of Alyssa Wright from Canada and Justin, who will chair today. And I also saw Prof. Sipho Dlamini, who will be speaking a bit later on. Welcome, Sipho. It's great to have you here from our own university. Look forward to listening to you too. So I think it's almost time to start. We always have a bit of a slow start to give everybody a chance to get in. So we're not going to rush everything here at the start. And what I can say, but Justin will then definitely be adding to what I'm saying, is that it's a perplexing and important topic, and one that we get frequent inquiries about. And from my side, Alyssa, I can just say that with Sipho many years ago, we sat together also with our immunologist, and we looked at what we should be doing. And, that helped us to put together a nice little, very basic, very plain vaccination schedule. So today we're going to speak about many things, not only about the post-transplant vaccination. And we really see this as an intro. We don't see this as the final conversation about it. So it really is, to me, to we can have the next slide, Gerdien, I think you. So just the plain, the normal things I have to say. And just apologies from Prof. Lowe. He was suddenly detained. And so I will be doing the housekeeping, chairing. And we know that the recordings are on Blood SA under resources, deep dive. And do use the chat box. We've left enough time in this meeting to talk, and we hope that there will be lively discussion. And then the CPD points is automatic nowadays at our Health Professionals Council. And we also have Melanie Davids as a contact point, which brings me to my next slide, which is the team. So it's me and Gerdien Kritzinger, our wonderful National Training Coordinator, who is making sure everything runs smoothly and at a high scientific level. Thank you, Gerdien. And then Melanie Davids, who is the administrator of the CPD and will help you with queries. So that's our team. And then next slide is where I'm going to hand over to Justin de Tooy. And Justin needs no introduction to the South African audience. We know him from, when was it? In 2016 that you returned to South Africa from Rotterdam, where you did your MSc, after becoming a physician, your MSc in virology, and you came back to us, and you was just one of the many past, and I am happy to say present, fantastic, brilliant, awesome fellows who are now already a hematologist and has started to carry the transplantation flag, or the transplantation vanguard, to bring this whole approach and this awareness, and also for patients to actually access transplant. So that's very, very near to Justin's heart. And this topic is like a little bit of a gateway to sick patients and to transplant patients. So I'm handing over to you, Justin.
Stel, thank you very much for that kind introduction. It's really appreciated. So all I can say today is that I'm just super grateful to have two speakers for today that's going to discuss this very complex topic of vaccination and hematology. And I think the reason is because most of our hematology patients, I mean, they can be quite, just because of the illness intrinsically, can be immunosuppressed, or because of our therapies that we often give, like rituximab, or allogeneic bone marrow transplantation, autologous bone marrow transplantation. All these things can lead to immune suppression. And we also know that these patients can complicate with infectious diseases, and it's a very common complication, actually the most common complication. So I'm just so grateful to have Alyssa and Sipho here today to help us prevent infections in our patients by means of vaccination. And it's like Estelle said, this is only an introduction. It's a very complex topic. I don't think we're going to have all the answers as yet, but it's something to be, to put people together and in order to answer all these questions. So firstly, I'm going to introduce Professor Alyssa Wright. So she's a clinical associate professor at the University of British Columbia. She's also currently the head of Vancouver General Hospital's Division of Infectious Diseases. She established a transplant infectious disease unit looking after basically stem cell transplant patients and solid organ transplant patients. And her responsibilities actually include the care of pre- and post-transplant patients at the Vancouver General Hospital and St. Paul's Hospital in Vancouver. She's also a consultant for the transplant and infectious disease issues in the organ donors and at the BC Cancer for infectious diseases in cancer patients. So quite a huge profile. But thank you, Alyssa, for being here and presenting today.
No problem. Thank you for that very kind introduction. So I'm just gonna share my screen. And I was given about 20 minutes to talk about vaccination in hematologic malignancies, which is quite a broad topic. So I'm going to do it from the perspective of what we do here in British Columbia, Canada. So let's get started. I do have some disclosures, although none of them are related to vaccination in particular. They're related to other things. So hopefully over the next 20 minutes, what I will manage to do is to share a little bit about the recommended vaccines for patients with hematologic malignancies in Canada. And you'll get a sense, even from my talk, about how we vary within Canada. So you'll be able to compare and contrast between here and also between South Africa after the second speaker. And then I'll describe a few of the ways we try to maximize the response in this vulnerable patient population. So this is a newspaper photo that I found. It's from the 1950s, where adults and children were lining up in New York City for vaccination against polio, which had been quite a problem for young children prior to that, and there was a new vaccine. I would have said a few years ago, this seemed very bizarre, but it is very reminiscent of our own experience, at least here in Canada, trying to access COVID vaccines. So I'll say there have been no shortages here of vaccine preventable diseases that have still been a problem. So in the last few years, we've had measles outbreaks, including a notification of some measles in at least Kentucky, the United States, over the weekend. There was a case last year of polio in New York State. There's an ongoing pertussis outbreak close to us in Alberta, Canada, and then the ever-present, unfortunately, ongoing COVID-19 pandemic. So lots of time to talk about, vaccination strategies, particularly for immunocompromised patients, and that's not going to go away over the next few years. There's an ever number of new vaccines that have come. I know there may be some that are more relevant to other areas of the world, but at least for us, the one that's most imminent on the horizon is RSV. So vaccination in the immunocompromised, vaccine preventable diseases actually do cause major morbidity and mortality for patients with hematologic malignancies. I think the two that get highlighted the most are probably the increased risk of invasive pneumococcal disease and increased severe outcomes with influenza, although I think if you looked for other diseases, you would find them as well. Updating vaccinations is certainly a critical part of care, although it can pose significant challenges. And we've spent a lot of time in the last few years with COVID, in particular, talking about how to maximize responses, because there really is some questions around the quality of protection or the duration of protection that you get. And then some small risks of adverse reactions, but they are present and patients do have, and providers end up with a number of questions. So just to frame sort of the first part of my talk, I thought I would do it around a case, and you can think about what you would do at your own center. So here we'd have a 65-year-old gentleman with AML who undergoes induction and gets into remission. And then ultimately, after some maintenance chemotherapy, undergoes allogeneic stem cell transplant. And at discharge, he then asks, can I get my COVID-19 booster? I got my notification. So here in Canada, you get notified by email or text when it's your turn to get booster vaccination. So what about the post-transplant setting? So here in Canada, we have a national immunization body. It's called NACI. You'll see me refer to it in the next few slides, which stands for the National Advisory Committee on Immunization. They acknowledge that both allogeneic and autologous stem cell transplant recipients have declines in antibody titers post-transplantation. There are quotes in the literature that 30 to up to 100% of patients will lose specific humoral immunity at 1 year, with other papers sort of suggesting that if you don't revaccinate them, any antibody titers that you do have, even at 1 year, will decline over the ensuing years. And I've just highlighted antibody titers because that's often the easiest thing to measure and what much of the literature is based on. But we do know that there are other measures of immunity, including cellular immunity, which we do not have good, easy access to in the clinical setting to sort of look at immunity in any setting, and in particular for some of the immunocompromised. NACI would consider both allogeneic and autologous transplant recipients as never vaccinated, and they would suggest that T cells capable of responding to new antigens are generated somewhere in the order of 6 to 12 months post-transplant, maybe slightly earlier in children and autologous stem cell transplant recipients, although overall the response is still diminished versus healthy controls. So NACI would suggest that in the pre-transplant setting, all routine vaccines are given, including a pneumococcal vaccine if the person was not of an age group where they were expected to get that. Of course, there are always issues with live vaccines in the setting of immunosuppression, but certainly all of the inactive vaccines can be given, and that you finish off any inactive vaccines ideally 2 weeks prior to conditioning. And if in the rare circumstance you had to give someone a live vaccine for whatever reason, and I will talk a little bit more about the ones that are relevant here, that you finish it 4 weeks prior to conditioning. We don't really talk a lot about donor vaccination, although there are some topics where this may be relevant. They acknowledge basically there are ethical and logistical issues around donor vaccination. And post-transplant, what they suggest is that you start pneumococcal vaccination and COVID vaccines at 3 months. Inactive influenza vaccine starts at 4 months, and all other inactive vaccines at 6 months, with live vaccines at 24 months, bearing some caveats, which I will talk about in a couple slides. And then they say, because we know these patients don't respond to vaccines very well, they suggest that if you're giving hepatitis B vaccine or HPV vaccine, that you use a maximal dose schedule, which can be either 3 or 4 doses or double the antigen load. So here in BC, I don't know if this was circulated, this is our revaccination schedule for post-transplant patients. And what you will notice is that we do not start at 3 months with pneumococcal vaccine. We actually start at 6 months for all vaccines. And I'll just highlight a couple of things. So one thing to notice is that, again, on the theme of maximizing vaccine response, we actually use a pediatric formulation of diphtheria, tetanus, and acellular pertussis, and not the adult formulation because it is thought to produce a better response. Again, this is not something the national body recommends. This is something that's done locally. We do 4 doses of hepatitis B vaccine, and we actually double the antigen load. That's what some of the superscripts mean. We do start with PCV13, followed in 3 doses, followed by PPV23, or the conjugate vaccine is first, because again, it is thought to produce a better response, followed by the polysaccharide vaccine. And then 3 HPV doses, which is, again, a maximal dose schedule. So I think what was circulated earlier was the Manitoba revaccination schedule post-transplant. And I don't know if you took a look between the two, but if you would have noticed some differences. So in Manitoba, in adults, they use the adult formulation of tetanus, diphtheria, and acellular pertussis. They start their pneumococcal vaccination series at 3 months post-transplant, similar to the national recommendations. However, they give 2 pneumococcal polysaccharide vaccines, one at 12 months after transplant, and then again at 24 months. And then they have decided there to use a combination vaccine product for both hepatitis A and B. So this would not be a higher dose hepatitis B product, but it would also contain hepatitis A, and they give 3 doses for that. So here in BC for influenza and COVID, because again, I said pneumococcal and influenza are often big topics in the post-transplant setting, and COVID has been a big topic for everyone. So influenza vaccine, at least locally, can start earlier during the influenza season. We start it between 4 to 6 months post-transplant, if that is the influenza season. In BC, even though it is not recommended by national guidelines, and there really is no data around this, if they get a vaccine dose between month 4 and 6, they actually get a second dose 28 days later. We do not here in BC offer the high dose influenza vaccine product. So there is a high dose product that was initially designed for elderly individuals because they also do not respond very well to vaccines. There is some data for SOT, but in general, this product is not used in BC widely, and it is something patients can pay for if they want to, but it is not freely offered. COVID revaccination starts at 3 months post-transplant, and we are still here using the monovalent vaccine for primary series, which has led to some confusion as to which product patients can get. So live vaccines are given here only at 24 months post-transplant. They do need to be off immunosuppression or cancer therapy for at least 3 months or 6 months if it's a B-cell depleting agent. They can't have any evidence of GvHD, and because IVIG or subcutaneous IG can actually bind up the live virus and prevent the vaccine from being effective, we say patients have to be off of it for 8 months. We really here in BC are only talking about varicella vaccine and MMR. Many of the other vaccines like BCG, which isn't really necessary in Canada, is contraindicated in the post-transplant setting. But even newer vaccine products like MMRV are not recommended by the national body, live influenza vaccine or rotavirus vaccine or live smallpox vaccine. There is some acknowledgement that patients could get yellow fever vaccine if it was absolutely necessary, but it is not something that is routinely given because it is not a problem here. It is recommended that we measure antibodies post-vaccination for response, and then there is some suggestion that if patients haven't seroconverted, that then if they were ever exposed, you would offer them post-exposure prophylaxis like immune globulin for measles or varicella-specific immune globulin for varicella exposures. Again, for GvHD here locally at the hospital where our transplant program is, we recommend not postponing non-live vaccines for chronic GvHD of any severity or grade in general. There is some wiggle room if patients are on prednisone greater than 0.5 milligrams per kilogram as part of combination therapy or 3 immunosuppressive drugs. They say you can defer, but we suggest not more than 3 months because I have seen some patients who get deferred and deferred and deferred, and then they completely forget about getting revaccinated in general. And then unfortunately, sometimes you've missed the window and patients present with vaccine preventable diseases. This is based on a paper which was based on some unpublished H1N1 data. So this is still an area where there is room for lots of study on how to best vaccinate patients. So in BC, at least, if you were talking about areas where we could improve or things that we do that, maybe we could relook at. So we don't start earlier with PCV13 in BC, despite the national recommendation. And that's really a recommendation that's based because pneumococcus is one of the most common increased infections in the post-transplant setting. The other thing is we're still using the conjugate vaccine with 13 serotypes, or PCV13. We're not yet using the conjugate vaccine with 20 serotypes, also known as PCV20. There was a statement just last month from the national body that this should replace PCV13 for elderly individuals and all patients who are immunocompromised. So we have yet to see where that will roll out here. We don't use high-dose influenza vaccine. We do use the quadrivalent meningococcal vaccine, but there's a new vaccine for meningococcus B, which is the more common serotype now that the quadrivalent vaccine is out there, but it is not publicly funded or routinely used in the post-transplant setting. There's some newer vaccines for shingles. So Shingrix is an inactivated vaccine, and I'm just using the brand name there to distinguish it from the live version called Zostavax. It's not publicly funded, and although we don't really know the best way to use it in the post-transplant setting, there's lots of interest, and there are some studies going on around the world. So hopefully in the future, this will be something we can look at, because certainly shingles is another vaccine preventable disease that is very common in the post-transplant setting. We don't have any data for that second influenza vaccine dose, so we don't really know what it's doing. And probably biggest of all, we don't really have good correlates for protection. So even for things like COVID, we don't know how many doses or how to vaccinate patients in the best way possible. So I'll move on and just talk a little bit more about some different scenarios for the remainder of my time. So this is a patient with AML who's undergoing consolidation chemotherapy, and you see this person during chemotherapy and they ask, do I need any other vaccines besides my yearly influenza vaccine? So this is someone who's just hematologic malignancy on cancer. So back to our national body, recommendations are again mainly around influenza and pneumococcal vaccine, because these are the vaccine preventable diseases that come up most commonly. But again, other encapsulated organisms can be a problem. So here, Haemophilus influenza type B is another vaccine that is recommended in the cancer setting, regardless of age. The suggestion is that you just follow the routine schedule for age for all inactive vaccines. Again, back to not being able to give live vaccines during chemotherapy. There is the suggestion that if you give hepatitis B or HPV vaccine, that you use a maximal dose schedule. So often it can be even again, back to the double dose that is given to patients with chronic kidney disease. There is the suggestion that once off immunosuppression, you repeat doses unless antibody levels can be measured. And again, no live vaccines until at least 3 months post-therapy, or 6 months if there's a B cell depleting agent in there. And then in terms of when is the best time during chemotherapy, they just say vaccinate 2 weeks prior to starting immunosuppression, or when immunosuppression is the lowest. And so I think this is an area which is still not very clear as to the best timing for vaccinations. So in BC, for patients with cancer, we recommend all routine inactivated vaccines and a pneumococcal polysaccharide vaccine, so not the conjugate vaccine, as well as Haemophilus influenza type B vaccine only for incompletely immunized individuals 5 years of age and older, and a yearly influenza vaccine. So you can see here some of the differences even between, again, the national body and what is recommended locally. There's some wiggle room for meningococcal vaccine if there's issues with the spleen or splenectomy, and again, the contraindications for the live vaccines. So why all this debate about these differences in the pneumococcal vaccine? So the conjugate vaccine was initially created for young children under the age of 2 who don't respond very well to polysaccharide antigens. And so there has been documented efficacy and effectiveness in patients with HIV, and there has been documented improved immunogenicity in patients who were post-stem cell transplant. So our national body would grade this evidence as good evidence of increased benefit from using the conjugate vaccine over the polysaccharide vaccine for those patient populations. There is minimal data in other groups like lymphoma or multiple myeloma, and so NACI would grade the evidence as fair for benefit of the conjugate vaccine over the polysaccharide vaccine. Unfortunately, what is determined nationally does not influence necessarily what is covered locally. And so BC has decided to fund the good evidence groups, the patients with HIV or patients who are post-stem cell transplant, and all other groups use the polysaccharide vaccine. It will be interesting to see what happens as PCV20, the conjugate vaccine with 20 serotypes, comes through the system, whether or not any of that will change. So in terms of when to vaccinate, this is for our influenza algorithm, and you can see here on your left that there's the chemotherapy patients, and ideally you vaccinate them 2 weeks prior to the first cycle. But at least for us here, when we're talking about between chemotherapy cycles, we suggest you do it when your blood counts are near the normal range. So they suggest an ANC greater than 0.5 and a platelet count greater than 50. Or some suggestion of timing being 2 days prior to your next chemotherapy cycle. So in terms of areas where we could improve, or we could look at some of the differences here, we don't give the conjugate pneumococcal vaccine despite the national recommendations. We don't give Haemophilus influenza type B vaccine unless you're incompletely immunized. There's no comment on giving high-dose hepatitis B vaccine or a 3-dose series of other vaccines like HPV. And we don't usually repeat doses of vaccines once patients are off therapy. And it's really unclear if providers are measuring responses, but things like pneumococcus, it's not widely available how to measure those responses. So I don't think that this is something that's going on in routine practice. What about household contacts? So again, we suggest contacts should receive all routine vaccines, including most live vaccines, because natural infection is worse. So here we would suggest that contacts not get oral polio vaccine, which is something that's not used in Canada, but that doesn't mean that it's not around. Actually, that was the strain that caused the case in New York State last year. It was related to a vaccine strain, and vaccine strain was what was detected in the wastewater when they looked. So certainly because people are traveling again, this is something that patients can run into. Live attenuated influenza vaccine is the main one that's kind of contraindicated here. And our national body and our local guidelines would suggest that if given, contacts avoid the transplant patient for at least 2 weeks. So finally, I will end with a third case. So this is a gentleman with relapsed ALL post-stem cell transplant who achieves remission with blinatumomab and then undergoes CAR T-cell therapy. This is something that is picking up steam here in BC, and they're about to sort of open their regular program. Prior to that, it was either research-based or patients went outside of Canada to get this. And so this person would know that they had been revaccinated post-stem cell transplant, and they would ask, do I need to be revaccinated again? And I will just say that it is unclear what is the best thing to do. We have no kind of national recommendations on this topic, and there aren't any local guidelines either, other than sort of some suggestions to revaccinate for COVID post-CAR T-cell therapy. It's really also unclear what's best in the literature, although again, if you want to look at sort of the things that are highlighted, really those infections with encapsulated organisms are the primary concerns. So back to pneumococcus, Haemophilus influenza type B, and meningococcus, those would be the big ones to talk about. So I will leave it there and just say that I hope the last 20 minutes I've managed to cover these 3 objectives, and I think there will be lots of time for questions or discussions at the end.
Okay, so I think maybe we can just, because I see there's 2 comments, Alyssa, or 1 question actually from Andrew McDonald. I think we've got some time to quickly answer that, and then we move on to Sipho Dlamini. So he
Sure.
actually, I don't know if you can read it.
Yeah, so the issue about starting earlier post-allogeneic transplant in South Africa would depend on what T-cell depleting therapy had been given. So post-transplant cyclophosphamide versus Campath ex vivo. So I think, T-cell depletion is something that's become more common here. We looked a number of years ago, and we've started, like from 2017, 2018 to now, we've dramatically increased the amount of ATG that we've used for GVHD prevention. So again, those concerns are that the patient's lymphocyte recovery is going to be delayed and that there may be a slower response. Currently, that's not something that's been reflected in guidelines either. So whether or not there's some benefit for us to wait for 6 months, I don't know. And it is, again, sort of highlights kind of, where the field goes and what we know about vaccines, and maybe how often things get updated can be really different. And so the question was about doing pneumococcal antibody titers. Some labs do total and some labs do serotype titers. It's different to correlate between the two. So I agree that actually isn't something we've had routinely available. We've talked about getting some option to measure pneumococcal serotypes, not so much for the transplant patients or hematologic malignancies, because I think it's probably just more efficacious to revaccinate if you're worried about response. But in the setting of low immunoglobulin G levels, there's some suggestion that if you vaccinate someone with pneumococcus and then measure and they get a vaccine response, they won't benefit from either IVIG or subcutaneous IG replacement. And that's the only area where we have talked about maybe bringing in pneumococcal titers. But I acknowledge that there is lots of challenges of doing this correctly in this field.
Thank you so much. So what we can do is, you guys are more than welcome to put questions into the chat box, please. And then the second speaker for this afternoon is Professor Sipho Dlamini. He is an associate professor in the Division of Infectious Diseases and HIV Medicine here at Groote Schuur Hospital. His clinical and research interests include tuberculosis, HIV, and adverse drug reactions in TB and HIV, and the use of vaccines in adults living with HIV. Sipho, thank you so much for your time, and we really look forward to your talk.
Thank you very much, and thanks for the invitation. I just want to put my talk into slide mode. Is it in slide mode or not yet?
Yeah, it is. Actually, it's not yet. But you can just put it in the.
Okay, right.
There we go.
Yep.
Perfect.
So thank you. So thank you very much. I'll just go back so that people can just remember who I am and where I'm from, and really to thank you for inviting me to speak today. And a really interesting topic, and you'll see the title of the talk is
Did we just lose Sipho? I think we did.
in preventing these vaccines. Hopefully by the end of this talk, I convince you that you should be vaccinating all your hematology patients. And you can see the question of how do you start? I think by the end of this discussion, it won't be about how, but when do you start, rather than the how, because I think there's enough guidance related to that. And then the question about where do you stop, I will reflect on at the end. So I'll just start off my talk by just giving some general reflections on vaccinations in general. And really the purpose for me is to give you my general reflections of vaccinating immunocompromised individuals, and share with you some very few thoughts I have. And then I think the richness is really in your contribution to the discussion rather than you hearing what I have to say on this. And I think Alistair has done a fantastic job in covering most of the issues. So I'm not going to go into the specifics about which vaccine to use when and where, but rather just cover some broad strokes. So I think I don't start my vaccine talks without showing you this sort of image of our history as human beings on this earth. And quite clearly, for most of our time, which has been almost 98%, if not 99% of the time, we have not been living beyond 30. And our ability to live beyond 30 really has been because of vaccines. So the availability of vaccines in preventing early childhood mortality has really led to our longevity in the past 200 years. And you can see that due to that, this Time magazine article even posited the question in the sense that how long can we live? Can we live up to 142 years going on into our future? And this is largely a contribution of our vaccination program across the world in early childhood. So yes, there are other interventions like access to clean water have made a contribution, but I will make the claim that it's largely due to vaccination programs across the world that we've gained these life expectancies since the 1700s. Yes, this issue about vaccinating adults has been an issue, and really one message here is that we've not really utilized the full potential of vaccines in adults. Many adults are dying of vaccine-preventable diseases across the world. The elderly and the immunocompromised are the ones who are most at risk and are dying. Many vaccines have been shown to be safe and efficacious in adults, and even data coming out to show that they can be cost-effective part of our armamentarium of treatment. And largely in many groups, especially the immunocompromised and the elderly, vaccine-preventable diseases is really a high burden and costing healthcare systems a lot of money each year. In the US, that figure is in the order of $5 billion every year. Just if you look at the top 3 vaccine-preventable diseases in terms of the cost to their healthcare system. So certainly across the world, there have been programs where guidelines have been shared with healthcare workers, but still, if you look at many clinics where those who need vaccines are not really getting them, and there are a complexity of reasons for that, namely the availability of the vaccines themselves, the cost of the vaccines, either to the individual or that the healthcare funders are not funding vaccines, so hence clinicians are not giving them, or clinicians not being aware of that, of vaccines and what to use in the patients that need them. So in your context, I think infection is a major cause of mortality and morbidity. And certainly you've heard that, infections like influenza and pneumococcal disease are something that hematology patients are highly vulnerable to, given their immune state. Certainly there is data that shows that many vaccines are safe for your patients. And again, guidance documents of what vaccines to use, how to use them, and that again, in many patients, that vaccines are tolerated. Of course, one has to acknowledge that there are complexities relating to hematology patients when it comes to vaccinations. It depends where you are and the predominant infections that are prevalent in your setting and which ones you need to prevent. And that also dictates what you give and how you give. Your therapeutics, in terms of your therapeutic approach to many of these conditions, may influence how you then give vaccinations and when you give when you give them. And some of these Alistair has really touched on. So the question of when is it meaningful to start vaccination is, I think, is important in your context. And that really relates to a number of factors. I've covered some of them, but not all. It will depend on the kinds of therapeutics you'll be doing for the patient, given the condition. Are you going to give them transplant? Are you going to, are you going to go for immunosuppressive therapy, or are you going to do both? And that may dictate when is it feasible to give the vaccine. Of course, there may be issues related to the vaccines themselves. So live vaccines, on the most part, are contraindicated in patients who are immunocompromised, but you can give them, and that depends on what your therapeutics are going to be. So if you can, some guidelines talk about, before chemotherapy, or some guidelines give guidance about after chemotherapy. For inactivated vaccines, again, there's some guidance either before chemotherapy, during chemotherapy, and then obviously after chemotherapy. And you may see some variation to this from center to center. Of course, the issue here is about really understanding your guidance and local epidemiology, but you do have issues where most studies aren't done in your patients, and if they are done, what is often done is that what you do is that people are mainly looking at immune responses to vaccination rather than true efficacy studies, because those often are very, very difficult to do, and then you need large patient numbers. So what often you'll see is the studies will just go to give a vaccine and you get immune response. And it's quite clear in many studies that are done, patients with underlying hematological malignancies or conditions tend to have reduced immune responses compared to healthy adults. Just remember, even healthy adults, this issue of what we do test is just immunological responses to vaccine, but we don't have a good clinical data about surrogates of protection. So, for example, the question that was asked about, antibody levels, what do they mean? Do they mean that at a certain level you have you're protected, or does it just mean that you've had a response and therefore we can infer that you've got good protection against that particular infection? There are going to be some exceptions in some guidelines about what you do when patients are given particular therapies. So those, for example, receiving anti-B cell antibodies, you'll see that there's a general reflection that you should delay vaccination for at least 6 months because of the effects on B cells. And then this issue about patients who undergo, stem cell transplant, should every patient be vaccinated the same way, or should you be doing some nuanced approaches to that? And of course, many of the recommendations don't really address this issue in particular. And just given that you don't have a data that really suggests that. So what you do see in the guidelines is just a general approach of what you should do. And hence you may see this variation from center to center. If you do look at some of the publications out there, about how and when and how you'd approach a vaccination in patients with hematological malignancy, for example. This is just a table from one of these publications where you see that as they list the vaccine preventable diseases, they talk about before or after therapy of what you should do. But of course, these are just general rules, and some centers may just take from other regions. But again, some regions may then develop their own nuanced approach, and we can have a discussion about this afterwards. This is again just to give to you a flavor, and Elisa has covered this in terms of approaches to vaccination in patients who've had a stem cell transplant, whether you do it before or do it after, and just some guidance about that. Many programs talk about just giving these vaccines after rather than before because of the lack of data in many instances. But more importantly is this issue about not how, but when. I think the message I want to give you is that you already have guidelines, especially in our country. So it's not about how, but it's really about when to do it. And there, your guidelines really help you. But despite having guidelines and across the world, many centers aren't offering vaccines to these patients who really need it. And when you look across the literature, you see these rates that vary from almost half of patients getting vaccines to some centers doing it very well with 97% compliance. Of course, there are many reasons why this may be so. Many areas of the world, especially in the global south, we don't have active programs for vaccinating adults. And South Africa, for example, is a case in point where we don't have a real national program for adult vaccination. We've got COVID-19, and I'll remind people in this country that COVID-19 is a special program. It's not a program that's really housed under a activity of Department of Health. And hence, not all healthcare facilities, for example, in this country, give COVID-19. Our hospital had to ask for special permission to be able to do that. For example, the HPV program in our country is a 9 to 14-year-old program through the school program. So it's still not under the Department of Health. And these are some contributing factors for why the availability of vaccines may not be there. Of course, there may be issues relating to clinical infrastructure to be able to house these vaccines so that they're able for clinicians to use. So I think for you, it's really to be aware that you should, and the when is really addressed by your guidance documents. And this is a document, for example, in Goedeskeer of a vaccination schedule, which actually tells you the when to do it, and is kind of similar to some of the international practice about using the vaccinations, and is quite clear guidance to help you to know when to do it. So the challenge really is for clinicians to be doing this actively in your clinical spaces for the patients that really require it. The next issue is, where do you stop? I think it's quite clear that our approach to vaccination in the last couple of years has changed, and it's more really about a life approach to vaccination or immunization. And there is a greater appreciation that one needs to be vaccinated across one's a lifetime. Hence, this life approach to vaccination, and you can see in the graph or picture in the slide that there are going to be key vaccines for different stages of one's life, and this is almost progress across one's life course. So while you're in utero, early childhood or infancy, in your adolescent phase, your adult phase, and then elderly. So when you probably stop is when one no longer exists on this earth. So I hope I can convince you that the question of where do you stop probably should not be a question of what we should be asking, but continually asking our patients, have you gotten the vaccine for the different life stage that you're in? I'm sure we can have further reflections on this during the discussion. So just to conclude, I just wanted to say that most of the recommendations in your space really encourage you to be vaccinating your patients and try to give you good guidance of when to do it. And most almost are saying that there isn't a need to be delaying, but of course there are some specific situations where that may be so. This issue that of donor vaccination has been covered, and most guidance documents don't really recommend that. But I think it may evolve. You may see some centers where that may be particularly done. The other issue, and more importantly, is to remember to possibly think about individuals that stay in close contact with those who are your patients, and ensuring that family members have their immunization status up to date according to where you are, so regional or country recommendations. And then, of course, yourselves as healthcare workers should make sure that your immunization or vaccination status is up to date, because there are certain infections that you may acquire and transmit to your patients. So the yearly influenza vaccine is one that comes to mind. And then, of course, I think the literature is quite clear that vaccines do save lives, and certainly avoids unnecessary hospitalizations, and that most of your patients, to a greater degree, respond to most of the vaccines that are available. And really going to end there, and happy to take further questions in the discussion.
So thank you very much, Professor Dlamini. So, wow, I see there's there's 2 questions in the chat box, which we will address. So Estelle Verberg asked, what would be the role of antibody titers in various revaccination schedules? So I don't know what you guys think of that.
Yeah, so I can start, and then Alyssa can also add in. I mean, there is this thing that comes up about the use of titers in various and as an approach to vaccination. And I think the message is that the literature is not really clear. It's divided because it's really difficult to know how you're going to use it. And especially if you're going to talk about people who are going to have stem cell transplantation. And there's an issue about what do those titers really tell you, and do they tell you that somebody is essentially protected? And it becomes very complex. The simplest way is if you're going to heavily immunosuppress someone, or even change their immunological profile. After you've done that, you probably do have to have some sort of revaccination, irrespective of what the titers tell you. The challenge is when do you time that? And I think that's where you're going to have a variation of practice, and the literature is also really, in some instances, not clear.
Thanks, Sipu. Just Alyssa, just from my side quickly, on our schedule, the one we made with Sipu and his colleague, we actually added the pneumococcal, the strep pneumonia specific IgG. So that would be, I suppose, the full serology that I think that Andrew referred to. We added it in before we started, and then after the second vaccine. But it's been thrown out there by somebody. I don't know why. And I would actually, I know I've done the ones I've looked at. Indeed, like you say, Sipo, it doesn't necessarily, and also Alyssa, you referred to, it doesn't really show much. The fact that it doesn't go up doesn't mean the patient will get infection. So, and if you look at the studies that's been done, I don't know what's been done in viruses or in other childhood diseases, but when you look at the studies done just for post-transplant pneumococcal vaccination, then you do see a varied response, isn't it? Varied. And the longevity is also varied.
Yeah, Alistair, maybe you want to go?
Sure. So I was just going to say, those are all great comments, and I would agree. I actually think they're probably more confusing than anything else, and I would hesitate to put too much value. There's a couple of things that you guys have identified, like, you know, antibodies for some diseases are great for preventing you from getting infection in the first place, but once you have infection, it's cellular immunity that keeps you from being sick. So COVID-19 is a great example of that, where we know even in patients who don't mount an antibody response, they still can have benefit from the vaccine. And that's been documented even before COVID. So hepatitis B, we don't usually measure antibodies post-vaccine, and yet we know a few people will show up, at least in North America, and blood donors who have converted to a core positive, have never had clinical hepatitis, have never been sick, but at some point have been exposed to hepatitis B. And so clearly the vaccine is working to prevent them from getting sick. Doesn't necessarily mean that it's on an antibody titer. So antibody titers are cheap and easy, and in some scenarios they may help, but they also may confuse the picture, and they can be particularly harmful, I think, if people focus too much on them and think, well, I won't vaccinate because this person's not going to develop an antibody response at all. Like, what's the point of doing it? We actually don't know that. The best outcome is kind of efficacy measures in large clinical studies looking at disease, and those are very hard to do, and often need large numbers of patients in order to show some sort of benefit. So I would try not to focus too much on it.
Alyssa, I've got a question for you. I don't know if you guys use any immune correlates in terms of looking at immune reconstitution, for example, a CD4, CD8 count, or immunoglobulin levels post-transplant.
So we don't. Interestingly, if you look at some of the blood references, I don't know if this is what SIPO was using, like at Fred Hutch, which is the large cancer center just across the border in Washington, they actually do use kind of CD19 levels or CD4 counts as a recommendation threshold before they begin vaccinating. So they ask that your CD4 count is, you know, greater than 200. We do not do that here. We go simply with, you know, your 6 months post-transplant, and you aren't on a ton of chronic GVHD medications. But even if you are, we ask that you don't delay too long. So we have not incorporated that. And I don't think there's, again, like talking about areas where there's areas for better evidence, this is kind of a classic one. We do have the ability to measure some of this. We just don't know.
And then I see Andrew McDonald had a question. I don't know if you guys can read it, or shall I read it?
I can see it's about not routinely doing meningococcal vaccine. You guys don't have Bexsero or the meningococcus B vaccine, zoster subunit not available, and also HPV. So with regards to the question about the HPV, we do have a strategy now for men and women. All grade 6 children here in BC get vaccinated for HPV. And so in the pediatric revaccination post-transplant, HPV is recommended, but there's also some recommendations for even women up to the age of 26, or if people have other risk factors like MSM, that they would still qualify. So there still are groups that are getting HPV across the board. And as these children who are in grade 6 grow up, eventually the whole population will one day be vaccinated for this.
Yeah, and I think just to add, in our setting, look, the HPV vaccine is an adolescent vaccine, and that's where it is, and it's only for children. I think, you know, with all the vaccines, you potentially could use them, but I think one of the challenges we have is where you've got resources as a limitation is who's going to pay for it, and some of the costs of these vaccines just make it not feasible to be part of your vaccination program. So I think the where to start really is where you've got a high disease burden. So I would just say the top ones for our country are going to be pneumococcal vaccination. That has to be almost 100%. Influenza vaccination has to be 100%. COVID-19 vaccination has to be 100%. I think we are muttering about RSV, pertussis, I think are also going to be those. And then obviously, I think definitely meningococcal and influenza B. Influenza B in adults in our country, disease burden prevalence low, but you're talking about patients who are immunocompromised, high risk. So I think it's a must, and probably should come is as highly recommended. I mean, if you're going to have a sort of a cost budget to it, I think you do have to kind of list them and list them by disease burden.
Sipho, and I think there's a question from Karen Gunther. I think she said they always delay zoster vaccine for some reason. Please, would you comment specifically on the timing of the anti-zoster vaccine and when to use Zostavax versus Shingrix, and the timing of the anti-zoster vaccine after a patient that actually had shingles?
Yeah, look, I mean, the shingles or Zostavax, remember, you've got two. You've got a recombinant, and then you've got the live vaccine. So live vaccines in these heavily immunocompromised patients probably not a great idea and shouldn't. The recombinant vaccine is a potential use. Now, it's difficult because you have to look for the studies. So the registration trials for the zoster vaccine was really done to look at its contribution to preventing shingles in the elderly, and that's where you've got very good data. When it comes to people younger than 50 and the patients we're talking about who are younger, the vaccine would be the recombinant vaccine to use, and here you're then relying on very small studies where people have looked at it. It's going to be a challenge as to when when is the best time to use it. And Alistair, I'm not sure what you do in your setting where you probably have ready access to it. We don't have it registered, I think, yet, or maybe it has been registered in the last year or two.
So this is an area, I think, which will be lots of growth. So we do also have financial challenges in terms of the vaccine program as a whole has a budget for the whole province. And so Shingrix or any sort of herpes zoster vaccine has not made it onto being free for people, and that includes in the post-transplant setting. So there is a cost to patients. And we don't really know the best time to use it because there is only one actual trial. So there was a small trial using the recombinant vaccine post autologous stem cell transplant, sort of starting earlier, looking at prevention of shingles, and there was a benefit. It just has not sort of translated into any sort of recommendations. There are other ongoing studies right now looking at where to use it. I think it will be a great option at one point because right now it's a little bit weird. We give valacyclovir for a year and then they're off valacyclovir prophylaxis, and it takes until month 24 when maybe they can get varicella vaccine, but that vaccine's not really designed for shingles prevention. It's designed for sort of antibody conversion. And most of these people still, we have childhood varicella vaccine, but we've only had it since 2006. So most of our adults still have been exposed to chickenpox at some point and are at risk of herpes zoster, and that is certainly something we see a lot of. I will say here, we have fallen out of favor of using Zostavax entirely. So all Zostavax is like 14 times more varicella strain than is in the varicella vaccine. The effect tends to wane after 3 years, whereas the recombinant vaccine, at least there's been some modeling suggesting protection lasts out to 9 years. So I really think, I think in the state, Zostavax has been removed entirely, and we here focus more on the recombinant vaccine just because the protection seems to be better. But that is something that I think would be great if we could incorporate into the schedule, and potentially even earlier, particularly because it is a recombinant vaccine and not a live vaccine, and shingles is a huge burden of disease.
Yeah, and I just wanted to add as well is that, you know, if in adults in immunocompromised, I know that the recombinant has been, a very small study has looked at it in HIV. And again, when they used it, they used CD4 count as a cutoff, so higher CD4 count. And, you know, patients having to be on antiretrovirals with a very reduced CD4 count. So, you know, for hematology, after, you know, severe immune suppression or transplant, you wait for immune recovery and use, for example, CD4 count as a threshold. You know, it's quite unknown, as Alistair is saying. You know, we do need more data to really give people an idea as to the best timing and best benefit of the vaccine.
Alyssa, I just have a question, another question for you. I was wondering, do you guys have nurse practitioners that kind of like champion this in your clinic, or is it mostly clinicians that actually specifically order the vaccine for the patient on specific time points?
So we have a clinical associate and a nurse practitioner, and they kind of do sort of day 100 and then yearly annual visits with recommendations for things like, you know, screening for other cancers because your risk of other malignancies goes up, and, you know, looking at the patient as a whole. And one of the things they do is recommend, you know, here's the schedule. Have you gone to the public health unit? And I think there was the suggestion that they were going to actually start collecting data as to how many of patients post-transplant have actually completed the vaccine series as a marker of kind of the quality of care in the program.
Okay, my second question is, and this is quite a controversial thing because we often use Polygam we give Polygam weekly to patients post-transplant for about 3 months. I don't know if other units do it too. That's what we do. But the thinking is that it actually prevents CMV reactivation. So I was wondering what your opinion is on this.
So I mean, the data from SOT would suggest that, personally, I haven't seen a lot of benefit with immunoglobulins as a preventative measure for a lot of these, although I do know that people are stuck. For CMV in particular, we are very fortunate that we have started using letermovir prophylaxis, and that has basically eliminated our CMV problem in the post-transplant setting. So I think, unfortunately, once you have antivirals, you don't have to rely on that. Now, whether that would prevent other respiratory tract diseases, I mean, the data is still all in these. It's certainly, the risk should go down for your encapsulated organisms. That's really where it was studied in hypogammaglobulinemia. But as to whether or not it prevents viral infections, that usually isn't the focus, although theoretically you are also probably transferring some of that antibody as well.
Okay, I don't know if there's any other questions from the floor. Doesn't look like it. Okay, any comments perhaps, or doesn't?
Hi, Justin. Can I just say, so I found this really helpful because basically it showed me there isn't totally a right and wrong, and we shouldn't be going on a formula. We should just be going back to thinking about what we're doing. So we want to vaccinate against the things that are the biggest problem. We want to pick a time as soon as possible, but when you have some chance of actually responding. So it actually is quite liberating. Thank you to talk about it like this.
Yeah, I was just going to say that, I mean, when you look at some of the literature, there's a view that you probably should be doing individualized vaccination in these patients given the complexity of some of the approaches you do in terms of treatment. But the problem is that's where we've got a big data gap. So, the best we have is just a general approach, and people appreciating the principles of what you're trying to do. And then maybe just a last comment from me is that really when we're vaccinating in adults, in children, we almost talk about disease prevention. But I think in adults, we are probably using it as a strategy, maybe not disease prevention, but preventing severity of disease and the morbidity associated with having a severe infection with one of these vaccine preventable diseases, because that's also ultimately what increases the morbidity and mortality in these patients. It's just the complexity of disease. So, that's the other thing that people should be aware of, is that we're trying to probably in many instances prevent the severe form of the infection that patient may suffer from.
Yeah, and I will just add to that comment, there also probably isn't a wrong time to vaccinate for a lot of these inactive vaccines. Like, as much as we want to personalize it, you also don't want to keep delaying and delaying and delaying until the person has, so far down the road that they've already had sort of the infection of consequence. Like, we can talk about, CD4 count or CD19 cell levels, but if we overthink it, you may miss your window as well. So I would totally agree with that.
Okay, so I think I don't know if there's any last questions or last comments before we say goodbye.
I do have a few more questions. Indeed, I think we can speak a long time. And for us who's been grappling with changing our schedules in a sensible way, and I mean, just listening to both of you, Alyssa and Sipho, there's a cost constraint, there's individualization. If we look at the schedules, and perhaps I've missed that it's changed, but the schedules, the guidelines for post-transplant vaccination that I'm aware of still advocates vaccination for the post-autologous transplant. Is that correct? So, I do not really think that everybody is being vaccinated post-autologous, honestly. Definitely not post-myeloma transplant. But again, we should probably think of individualizing it. So that is one great gap. It's written there, but we don't. So I don't know if other units do the post-autologous transplant vaccination. Then I have a little provocative question here. I do believe in the, otherwise I wouldn't care about it. I'm the one who started vaccinating in Cape Town, where it was actually not done. The patients were sent to the clinics, I was told, but no clinic in South Africa will give a vaccination to an adult. Correct, Sipho? They won't. So it was actually just fobbing off. It was, they will get it somewhere. No, they won't. That's why we started our own program. So I do really believe in it. I do want my patients to get the best coverage. But isn't there also a role in this vaccination for herd immunity? Isn't it a sort that goes both ways? It's not only for my patient. Because I must say, the patients in Cape Town unit seem to be doing just fine before I started the vaccination schedule. I do not know how many lives we saved by doing it. And actually, patients do have so many other comorbid events when they're post-transplant that actually also contribute to morbidity. So now it's two questions kind of. The one is the autologous and the other one is just taking note of the individualization for the post-allogeneic. Also taking note of the great discrepancies in Canada with, polysaccharide versus conjugate choices. Luckily, I think, Sipho, we've made a plan for South Africa, and I suppose we can live with that one. So everybody who doesn't know, we did write a guideline, and I think we'll just do with that one. It was done with thinking of serotypes, thinking of what was best for South Africa. So my story is out, but we'd love to hear perhaps what Elisa has to say about the autologous and then the individualization.
So there definitely are papers looking at autologous stem cell transplant patients, and they do lose immunity over time if they are not revaccinated. And so for that reason, we do not differentiate between autologous or allogeneic, and we recommend revaccination for both. And so I do think there is a benefit. Someone in here has put probably at least the high-risk diseases. I would agree with that. Certainly, those patients have undergone quite extensive immunosuppression to the point where you need to rescue them with their own stem cells. And I do think there is some benefit. In terms of herd immunity and its effect, I think it definitely, there is benefits, particularly in certain diseases, to vaccinating groups and finding declines in disease. So the classic is pneumococcal disease. So when you vaccinate young children, and that has been seen in hematologic malignancies. So in some of the European countries, they have looked and they find that overall, as pneumococcal vaccines improve for young children, the rate of infection with pneumococcus, even in patients with hematologic malignancies, there is a benefit there. So there is some herd protection. That's not true for every disease, though. So I think, unfortunately, COVID is one where we have yet to find a benefit from vaccinating other people. You really vaccinate to protect the individual person, and the evidence is kind of conflicting as to whether that protects other people. And so I would also always encourage, if people are at risk of these diseases, as much as they derive immunity from herd immunity, and it's great to vaccinate the population because there are benefits, that there also is still benefit to vaccinating the individual, particularly in certain diseases where herd immunity may not be such a big player.
Yeah, no, I think I would agree with you for your comments, Alistair, as well. And I just say that in South Africa, in terms of the pneumococcal vaccination program, so given the rollout of the childhood vaccination program, we still haven't had the herd benefit as people like, in the US, where that program has had an impact on the elderly and in some immunocompromised individuals. Hence, when we vaccinate adults in this country, we have to use both the conjugate vaccine and the polysaccharide vaccine just to get broad serotype coverage. We're looking forward to the higher conjugate vaccines, so PCV20, which will probably take us another 6 years to get to this country. When these new vaccines, and we need it here because the risk of infection in our patients is almost 7 to 10 times the risk of healthy individuals. So we need these new vaccines, but it takes us about 7 years usually after a vaccine is released in the global north before we get access to it on this side of the continent. And even once it's registered, its translation to getting it into somebody's shoulder takes a couple of years because we have to put the infrastructure, train or educate or alert clinicians about the availability, and and then also negotiate who's going to pay for that vaccine.
Okay, thank you. Estelle, do you want to do the concluding comments?
I've thoroughly enjoyed it. I must say it's been quite complex, even though both speakers kept it very simple. Just shows you how complex it is. It is a vast, vast field, and it was really, really great, Justin, and everybody will agree to learn about various aspects. I hope, and I think the next step, Sipho, should be that in South Africa, we just share our protocols with each other and then decide upon an renewed version. I did make a remark, sorry, I may have missed it, but I did make a remark about the HPV. I'm asking our pharmacists now, will be able to use it in the older woman who's been transplanted? I don't know. So I think somebody shared, I think it was Andrew that shared that it's not available. Is it absolutely not available in South Africa for the older person?
I think for what I know is in the public sector for us, for example, in the state, we may have challenges accessing it because it's part of the, the adolescent program, which is housed under the Department of Education. So we would have to get our PTC to allow us to use it under special conditions. I think in the private sector, they probably have easier access, but the challenge there also in the private sector is actually getting the health funders to fund this. But I think that's where we as vaccinators can play a role in advocating, writing the guidelines, giving guidance to how to use it, when to use it, and how many doses, which vaccine to use, etc. So I think that's where we really come in and give sort of guidance, protocols, and advocate for both the state and the private sector to unlock the vaccines for our patients.
Yeah, so I look forward to working together. I think it will be great. What do you say, Justin, to just broker this? And we can do that also on the BMT classroom. It's a great forum for discussion, and we can start sending around. I see there's somebody wanting the GSH protocol. I must confess, I've always been very open about it. I got it from ActLife, and I changed it a bit for us. So I think ActLife, let's start again. Let's look how we can incorporate new ideas into the vaccine protocol, and also perhaps make allowance for these not routine auto, but where we do start thinking of them and perhaps, really focusing on what they need. Alyssa, we really appreciate it, and we hope it's not the last time that you are going to be gracing us with your very, very vast knowledge. We thoroughly enjoyed it, and you made very complex matters simple. And Sipho, I trust that we will have much more vaccine adventures in South Africa together. Thank you very much. And Justin, thank you for chairing, and thank you for always enthusing us to get on with the job. So we look to you to hear when we're going to do something new in the vaccine field. Okay. Thank you for the thank you for the audience. Thanks for being here, and please let us know how we can help